I'm just going to kind of outline the few issues that that they outline in this that the authors outline in this article. And they start out really by saying, look, 80% of physicians are now employed by hospitals, health systems, and corporations. Many factors have kind of contributed to this. I have some friends that are physicians that used to own a practice and then they sold to a local hospital system. And one of the things that they said was, you know what? It's nice to be able to come in and see patients and take vacation when I want to take vacation and not have to worry about payroll or managing people or the budgets for the clinic. Like all that administrative burden is gone and I can just quote unquote be a doctor. And I think there's some real value to that, something to it anyways, when you think about the drive to consolidation. Clinicians, and I've said this before, clinicians have gone into healthcare because they want to serve people. It is very much, I know this is true talking to my grandfather, who's a vascular surgeon, talking to some of my friends who are physicians. Like, it is very much the majority of people, or a lot of people that go into healthcare, view it more as a calling or a vocation that they happen to do to make money out of. Of course, there's the drive that is a safe, secure, stable career field. There's always going to be sick people. You always have a job. There's that. But by and large, a lot of the people that go into healthcare genuinely go into healthcare because they want to be clinicians. They want to serve people. They want to treat patients, right? They don't necessarily want to be involved in the administration, in the managing of people, in the hiring and firing and running payroll and compliance and all of that, which is why like management companies have kind of built up around physician practices as well in order to kind of alleviate some of that burden. However, one of the other factors that is driving some of this consolidation, not only is it the clinicians themselves wanting to just be clinicians, and it makes sense to sell the practice and not have to do the management of the practice, but really just be a clinician. There's also the shift from fee-for-service models to more value-based payment methods. And what these models require of clinicians and clinician organizations is management of budgets. A lot of it is data compliance. Some of the things that they mention in this article in particular, again, it's called value-based payment and vanishing small independent practices. They talk about the shift from fee-for-service to value-based payment models. These payment models require clinicians to manage a budget or a spending target for a subgroup of their patients. And this can include global budget contracts, like accountable care organization contracts, as well as bundled or episode-based payment models. What it boils down to is it's not just anymore. A lot of these payment models, these value-based payment models, don't involve simply the patient comes in, the clinician provides a service, provides a treatment, and then bills for that service or that treatment and gets paid for it. It now involves, maybe this is the patient's 5th visit in a course of care that should, maybe take 6 or 8 visits, and the physician's already been paid for these visits. And then there's maybe an incentive at the end if they get them done in less time. So it becomes more complicated, right? Not that it's right or wrong. In fact, if given the choice, I do think some of the value-based payment arrangements that we've come up with recently are more beneficial for patients than fee-for-service. Because fee-for-service, I mentioned this in the book, it's right here, Better Outcomes, A Guide to Humanizing Healthcare, that the fee-for-service model of healthcare really incentivizes clinicians to bill as many billable codes as possible in the least amount of time, which typically means that you're getting mediocre or just viable healthcare services that might not necessarily be, not that they're not in the patient's best interest, but that they're not the most effective, right? Because maybe the most effective treatment isn't covered. There's no code for it. You can't bill for it. And I've mentioned this before on different podcast episodes. Like, we at the clinic that I run have a couple contracts with lump sum payments. And essentially what happens is the insurance company says, listen, this is, Mr. Smith has this condition. Based off the evaluation, we'll pay you X number of dollars. You can treat them for as much or as little as you want, but you've already been paid. And sometimes oftentimes we find that those patients, we're able to do things with them in the clinic, one that we wouldn't be able to do with other patients because we don't have to worry about it being covered or not covered. We've already been paid. So if we want to do telehealth, we do telehealth. If we want to do remote patient monitoring, we can do remote patient monitoring. If we want to do some sort of, I don't know, use a modality or an intervention that might not be covered by normal insurance or typically not covered by insurance, we can do that because we've already been paid, and we can do what is best for the patient, the right type of care for the right patient at the right time, and not necessarily worry about the financial repercussions. Now, on the back end, it means we need to manage those patients in a different way, right? We've already been paid for those patients, which means we need to manage their care in a way that we're not going to go into a financial deficit and go out of business treating them the way we want to treat them, right? So there's always a little give and take there. But value-based payment models put that, in a large sense, put that responsibility on the provider and not the payer, right? The payer doesn't necessarily need to worry about how much is being billed or how much is not being billed and whether this service is necessary or appropriate or whatever, because they've already, in a lot of cases, paid this lump sum or paid this episodic payment. They don't necessarily, they're not incurring additional costs. They paid once and they're done. And then there's like, we can talk more maybe later about like shared savings incentives and the like. That's a little different take on value-based arrangements. But for these episodic or global like lump sum payments, that's how it works. That now it's no longer the insurance company's job to monitor what's being billed and what's not being billed and the amount of time being spent on a patient. That's now the provider's responsibility. And that provider now needs to manage it in a way where they're able to cover their overhead, pay their clinicians, maintain profitability, and deliver quality and acceptable patient clinical outcomes. So the burden now shifts onto the private practice, in this case, to manage that. And one of the things they say in this article is that the increased cost associated with managing those types of payment models is simply too much in a lot of cases for private practices to do it and do it competitively when compared to a large healthcare system or a large corporate healthcare company that has scale and operations and maybe even the technology stack to handle that. So the demands, another thing they say in this article is, quote, the demands on smaller independent practices creates a buyer's market for corporate owners who can leverage capital, management, and scale. So again, this idea that we know value-based payment models are coming. In a lot of ways, we recognize that they need to be implemented in order to make healthcare affordable again, but in order to ensure that we're providing the most valuable service, the most effective service. I don't want to use valuable twice there. The most effective service for patients, and not be reimbursing or not reimburse clinicians for the volume of care that they're providing, but really the quality of that care, the outcomes associated with that care. So a lot of times, the large corporate healthcare companies out there have capital, meaning money. They have management, and they have scale, meaning they have a large amount of money to kind of maybe float operations while they figure something out, or just to invest in treatments and services that might be more expensive but require less treatment overall, and the like. Management, so they're involved in, they have professional managers involved. A lot of independent private practices are owned by clinicians, are managed by clinicians who didn't necessarily go to school to become managers. They don't have the training to be managers, and that has implications for the operations of the business, right? And then scale, if United Healthcare wants to buy, I don't know, some kind of maybe protective gear, masks or something like that as a good example. They can get them for $1 in a mask because they're going to order 100 million of them from the supplier, as opposed to a small private practice that might only order a couple hundred, and now they're spending, $10 a mask, whatever it is. These numbers are totally made up, but you get economies of scale, not just in purchasing power, but then in the management, right? Like if you buy, or if you're a big hospital system and you have a management team in place and you buy 3 or 4 practices, you don't necessarily need all the overhead of their management teams because you've got a management team. Maybe you keep 1 or 2, district managers or regional managers to oversee the individual clinics or something like that, site managers. but the big bulk of that administrative burden then gets centralized in the mothership, if you would. And it decreases the overhead of operating the business, increases the profitability. And that's something private practices or private independently held practices can't do necessarily because they're doing it all.
If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo.